All right, so welcome to the last presentation on Krok 1 2016 booklet, 2016 booklet. Let us not waste much time. Let us begin. So Parkinson's disease. Parkinson's disease. Parkinson's disease. First of all, who can tell me where Parkinson's disease occurs in the brain? Is it in the brainstem, the midbrain, or the cerebrum? Who can tell me? Oh, nobody?
Midbrain.
Midbrain, thank you. Midbrain. Midbrain. And where do you think the corpora quadrigemina can also be found? Guys, you're revising. Corpora quadrigemina. You remember we talked about superior and inferior, right? Colliculi.
Yes.
Where do you think it's located or is found? I mentioned it several times.
Midbrain, sir.
Midbrain also. Midbrain also. Midbrain also. Midbrain also. All right. But that's just by the way. That's just a revision. So Parkinson's disease is caused by disruption of dopamine synthesis. What brain structure synthesizes this neurotransmitter? Meaning that with Parkinson's disease, we deal with what? The dopamine neurotransmitters. Dopamine neurotransmitters. So therefore, if you're talking about Parkinson, we are definitely referring to what? To the substantia nigra. Substantia nigra. Substantia nigra. So your answer here is what? Is C. Your answer here is C. Is C. So this substance is what is normally affected because they helps in the synthesis of dopamine neurotransmitter. So when that part of the brain is disrupted, what it means is that there will be a disruption in the dopamine synthesis, and so therefore the development of Parkinson's disease. So your answer here is C. Name the halogen. Who can name 3 halogens? 3 halogens in the periodic table, just 3. Who can tell me? 3.
Fluorine, fluorine, iodine.
Good. Fluorine, chlorine, iodine. Very good. Excellent. So these are your what? Halogen containing what? Substances or compounds or element. So the question is what? Name the halogen containing antiseptic with fungicidal properties, which is used to treat dermatomycosis. Now, assuming you don't know what all these things are, but at least if you know what your halogen, please, someone's microphone is on, kindly mute it. All right, awesome. So now, assuming you don't know all of these substances, however, you know what your halogens are. Guys, you know, be found wanting, isn't it? So quickly, over here, you will be dealing with what? You will be dealing with iodine solution. Iodine solution. Iodine solution. All right. Due to severe pain syndrome, a patient was prescribed with a narcotic analgesic. Narcotic analgesic. Name this drug. Name this drug. Guys, what's your answer?
Morphine.
Morphine. Thank you. Thank you. Thank you. But what is usually the drug of choice when it comes to giving narcotics? I mean, analgesics. The drug of choice. Can you remember? Okay, it's an assignment because I've said it before and we've said it several times. Yeah, someone is on this try.
Procerin, Pomidor.
Are you asking or you're telling me? Guys, try and remember it. We've talked about it several times.
It's Pomidor. It's Pomidor.
Okay. So the answer is yes, what? It's B, guys. B. Over here, I don't know if it was B. All right. During pathomorphological renal investigation of a patient who for a long time had been suffering from osteomyelitis. Osteomyelitis. That's infection of the bone. All right. And died of progressing renal failure. The following was revealed. Deposit. Look at it. Deposit of homogeneous eosinophilic masses in the glomerular mesangium, arterial and arteriolar walls. The stroma, which colored red when stained with Congo red. Guys, Congo red. What pathological process is this? What pathological process is this? So I think we have talked about this thing before, that when some substances, an abnormal substances get inside the nephron or inside the kidneys, what they do is that they can accumulate. They can accumulate. And when they do accumulate, they can cause what? Kidney failures. They can cause kidney failures. But again, over here, they are saying that it stains what? When stained with what? Congo red, it becomes what? Red. Isn't it? So what comes to mind? Who can tell me? We've talked about this. What comes to your mind? So what you're doing what? Some kind of what? Exactly. Some kinds of abnormal proteins that are being found. Some kind of what? Abnormal proteins that are being what? Found in the kidney. So yes, you are dealing with what? Amyloidosis. Amyloidosis. But is this disease a primary amyloidosis or a secondary amyloidosis? Anyone?
Secondary.
Secondary. Why?
The person has been.
Originate.
Who is talking? Okay. So all of you are right, because it's not originating exactly from the amyloid, or amyloid is not the primary cause, or the kidney is not the primary cause of this amyloid, isn't it? But rather it's coming from the infection that the person has been suffering from, isn't it? So this is the primary infection or the primary cause. So this then becomes what? A secondary process or a secondary disease. So over here, your answer is what? Amyloidosis. Your answer is amyloidosis. All right. During experiment, a dog has developed conditioned. I think yesterday some of you were confused about conditioned and sympathetic and all that kind of stuff. Even though that's the question over here, but I just remembered. During experiment, a dog has developed conditioned digestive reflex in response to a sound stimuli. In response to a sound stimulus. This conditioned reflex will not be exhibited anymore after the extirpation of the following areas of the cerebral hemisphere. In other words, if you take some part of the cerebral hemisphere out, you will not hear this reflex. That's what it means. That means the person will not be able to respond to what? Sound stimulus. Sound stimulus. So over here, what part of the brain controls sound or is responsible for sound? Yes, I know you people know of the quadrigeminal bodies, the superior and the inferior. Yes. But again, and of course, you know the vestibulo-ocular nerve or, areas in the brain. What else is responsible for sound stimuli? So over here, let's note the following. The temporal lobe. I think I've asked you guys to deal with some of these features or functions. The temporal lobe deals with hearing. Temporal lobe, they deal with what? Hearing. The post-central gyrus, they deal with sensory information. Sensory information such as touch. The pre-central gyrus, they deal with motor information. Motor information. What about the occipital lobe? What does it deal with? Who can tell me? The occipital lobe, what does it deal with?
Vision.
Vision. Vision or seeing. It deals with these things. So please put these things at the back of your mind. If you have this at the back of your mind, you have no issues with anybody. So both sides of the temporal lobe, is when they are taken, they will have impairment of sound stimulus. So over here, you are thinking of what? Of E as our answer. E. as your answer. Not one side. It is both. All right. Coenzyme A participates in numerous important metabolic reactions. It is a derivative of the following vitamin. A derivative of the following vitamin. Actually, coenzyme A is a derivative of vitamin B5. Vitamin B5. This one we don't teach you, you just know it. You should just know it. All right. No shortcut. All right. So like I said, vitamin A. Coenzyme A comes from vitamin B5. Vitamin B5, and this is a water-soluble vitamin. Water-soluble vitamin. Now, another name for vitamin B5 is the what? The pantothenic acid. Pantothenic acid. Another name for vitamin B5, pantothenic acid. So, of course, we can conclude that coenzyme A is a derivative of pantothenic acid. Pantothenic acid. Pantothenic acid. So over here, your answer becomes what? A. Your answer is A. All right. A patient diagnosed of acute dysentery has been treated for 3 days in an infectious disease hospital. On admission, there were complaints of high temperature, stomach ache, and fluid excrement with mucus up to 8 to 10 times a day. First of all, okay, they've already told you the disease is what? Acute dysentery. But what do you think is the causative agent of acute dysentery? Who can tell me? Anyone who can tell me this?
Shigella.
Shigella. Thank you. So this is what? Shigellosis. Another name for shigellosis is dysentery or acute dysentery. And sometimes if you don't take it, you can confuse this with ulcerative colitis. In Krok 2, you have these similarities a lot. In fact, they come in Krok a lot. In Krok 2, you will find them there plenty of such questions. So please take note of that. Now, one of the difference between the ulcerative colitis and the shigellosis or the dysentery is that the diarrhea in dysentery is so high. It can lead to severe dehydration. Severe dehydration. All right. But that's not the case. Over here is what sample should be taken for analysis. This person is going or is having diarrhea 8 to 10 times. So what do you think will be the best sample for analysis? Who can tell me? The best sample for analysis is what?
Feces.
Of course. Feces. A. Of course. All right. A patient with arthritis has been prescribed with an anti-inflammatory selective COX-2 inhibitor. Selective COX-2 inhibitor. Select this drug among these given below. So what it means is non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. So over here, which one of them is a non-steroidal anti-inflammatory drug? And your answer is what? Of course, A.
Yeah.
Of course. All right. And of course, you know it blocks COX-1, COX-2. But this one, very, very specific with what? COX-2. So it blocks it. And who can tell me the reason why you don't take these kind of drugs when you have ulcer? Who can tell me? Anyone with good pathophysiology background. I mean, with good, pathophysiology background. Who can tell me why you don't take non-steroidal anti-inflammatory drug when you have stomach pains or this kind of stuff? Who can tell me?
Because it blocks COX-2, and COX-2 is maybe COX-2, the function of the receptor enables is it prostaglandin E2?
Good.
To secrete mucus to the stomach so that it will prevent ulcer.
Awesome.
And now since it's blocking it.
Good. Very good. Thank you, doctor. So what it means is that actually our stomach is protected by what we call prostaglandins. They are protected by prostaglandins. So anything that is going to cause the removal of the prostaglandins or decrease its secretion, it means that you're going to be left unprotected. And that is why people who come to us with stomach ache, just stomach ache, would never, ever give a non-steroidal anti-inflammatory drug. Because some people come with stomach ache and they give them diclofenac. And diclofenac is a non-steroidal anti-inflammatory drug. Now, if you give diclofenac or ibuprofen, you are going to cause more harm than good. So instead of giving these sort of analgesics, you have to give what we call what? Tramadol. One of the things that we use a lot. Tramadol. You have to substitute with tramadol. Very good. We are learning. So please, you are going to be applying these things in practice. So take note of that. Sometimes the nurses get confused, and then when we are not there, people come with stomach ache. Oh, anything analgesic, they'll go and give diclo. I say, hey, never do that. If you do that, and the person is having ulcer, is going to cause more harm than good. So please, always take note. Always ask that question. Do you have stomach pains? Do you have ulcer? Ask before you give any analgesic. Ask. All right. A patient with a fourth blood group, that is genotype of what? AB, has in its erythrocyte both antigen A, controlled by an allele A, and an antigen B, controlled by an allele what? B. This phenomenon is an example of the following gene interaction. Guys, who can tell me? I will not waste my time on this one. Who can tell me?
Codominance.
Codominance, because A is expressing itself in the presence of B, and B is also expressing itself in the presence of A. This means that we are co-exhibiting or we are co-living. As simple as that. Nobody is superior than the other. Now, in the case of blood group A, which means that we have what? This as the genotype. We have this as the genotype. Means that this O will not express itself. It becomes what? Recessive. And then A becomes what? Dominant. So in blood group O, we can talk about what? A dominant what? Gene. Dominant what? Gene, which is what? Or dominant allele, which is what? The A. So please take notes. Over here, we're having what? Co-dominance. We are all living together. Don't come and stress me. So the guys who always want a lady to stress, I beg, ladies, wisen up. Okay? So we all co-dominate. All right, the answer is D. But please, ladies, you have to be submissive. Never forget that. Okay, come and beat me in my room. Faustina, come and beat me in my room.
I'm coming.
Come. A patient with diabetes mellitus suffers from persistently no healing of a surgical wound, which is a sign of tissue tropism, disrupted tissue tropism. What is the cause of such disorder? What is the cause of such disorder? First of all, what is diabetes? Who can tell me? What is diabetes? Nobody knows
Too much
diabetes?
glucose.
Yes, too much of what? Glucose in the body is what? Is diabetes. Now, you must now understand that sometimes people with diabetes have difficulty in their wound healing. And that is why sometimes we might end up even amputate them or cut off the place that is having a wound. Yesterday, I was on duty and I had a client who said there is a lump in the inguinal area. Okay, inguinal area, the left inguinal area. Then I asked him if he has any sort of wound in his leg. Unfortunately, he's having a big wound on his leg, on his left leg. For 4 good years, it has not healed. Guys, for 4 good years, that wound has not healed. What does it mean? What it means is that is why there is what? that lump in that inguinal area because the lymphatic system is trying to drain it, isn't it? So, and don't forget, we talk about the lymphatic system, that anything around the lower limbs and stuff like that, they all drain into the superficial, the superficial venous area, superficial lymphatic area. That's what they all drain into. So when people come with that kind of groin pain or groin lump, just know that there could be something around that area or an infection is, around the corner. But then again, what do you think helps in healing or in cell growth? What helps in cell growth? Who can tell me? Cell growth. What helps in cell growth? Proteins, exactly. Proteins helps in what? In cell growth. We've talked about this before. Proteins help in cell growth. And don't forget that every day your skin peel or part of your tissue undergo apoptosis, meaning they die off naturally and new ones are being replaced. And they are all happening so because your protein metabolism is working properly. Now, people with DM, they have a problem. They have a problem with regulation of protein metabolism. And we know that protein is involved in the cell growth, because if you have a wound, what actually prevents the wound from lasting is what? A cell growth, that new tissues will replace the damaged area. But here the case, because of diabetes, it is affecting the regulation of the protein metabolism. So what means that protein is not able to metabolize very well in order to replace the lost tissue. So eventually, what happens? The wound doesn't get healed. Or even if it does, it will take quite a long time. So please always take note of that. So over here, we will be talking about what? About disruption of the protein metabolism regulation. So your answer is C. A patient with signs of intestinal infection like vomiting, diarrhea, abdominal pain has been presenting with increasing symptoms of intoxication for 3 days. Papular rash appeared on the uncovered skin areas and spread to the torso. A doctor suspected pseudo tuberculosis. That means false tuberculosis or something trying to mimic tuberculosis, isn't it? Pseudo tuberculosis. What lab test allows confirming this diagnosis with the first week from the onset of the disease? So of course, this is also a form of bacteria, isn't it? Or what is the causative agent for tuberculosis? Who can tell me? Causative agent for tuberculosis is what? I'm not hearing you. You said gram something.
Mycobacterium.
Good. What? Bacterium.
Mycobacterium.
Yes. Mycobacterium. That is what causes tuberculosis, isn't it? And that is a form of also what? A bacteria. Isn't it? So if you want to analyze in the lab, what kind of test are you going to do to find out this one? Definitely, you will have to do what? Bacteriological analysis or investigation. Bacteriological analysis or investigation. This helps you to identify the organism with a specific kind of what? Staining and culture. And this is the reason why we do culture. So sometimes when you have infection, too much of WBC, the next thing to do is to do a culture to know the exact kind of what infection that is happening to the person. When you do the culture, you are more or less doing what we call bacteriological analysis. Very good. So that is what we do. So it will help you to identify the specific what organism. And like my brother was saying, something about gram negative, gram positive, maybe they can all come in to play. All right. So what your answer is D. A microslide demonstrates an organ with its wall consisting of 3 membranes. The inner has a tubular organs and undergoes cyclic changes. Guys, cyclic changes. Ladies, this is for you. The inner membrane has a tubular glands and undergoes cyclic changes. Every month, that place changes. Who can tell me that place?
Uterus.
Uterus. Exactly. Uterus. Every day your uterus change. I mean, not every day. Every month. Today it will be bleeding. Tomorrow it is fire. Tomorrow it will be bleeding. The next day it will be fine. It will be bleeding. Next day it will be fine. So please, you or we are dealing with what? The uterus. We are dealing with the uterus. It keeps changing. It keeps changing. It keeps changing. It keeps changing. When there's no implantation, it will change. When there's implantation, it will change. So every day, something new is coming. So may God bless all ladies. All this, God bless you all. All right.
Amen.
Those who didn't say amen, I don't know what you are doing. Anyways. Okay. But I know you said amen. With that.
Amen.
Very good. A patient with femoral neck fracture. Femoral neck fracture. Okay. Who for a long time had to remain in bed, guys, in a supine position. Now, what do you think will happen to you if you lie on one side of your body for a very long time? What will happen to you? Who can tell me? We've done this before.
Bed sore.
Yes. But what does it really mean by bed sores?
Necrosis.
Come again? It's what we call like the pressure ulcers, okay? Or when all the fluid, because now, if you lie at one side of your body or at your back, know that force of gravity will be acting upon you. So everything or any fluid that is on top will start coming down, isn't it? I mean, they'll all try to settle down. True or false? And that puts a lot of pressure on that part of the body that is lying down. And that's the time when you are sleeping, even you, when you are sleeping naturally. I mean, Faustina will tell you, when she's sleeping, we have a big bed like that. One big bed be like that. When she's sleeping, okay, she'll be on the edge, before you realize she's on the other edge. Faustina, true or false?
It's not true.
They say it's not true. They say it's not true. Me, I don't know. They say it's not true. But what I mean is, if you lie on your right hand, before you realize, you have to turn. In the middle of the night, you need to turn to your left, to the next side of your body. Then you will lie straight. Sometimes you even lie on your stomach. I know those people. I know them. I don't want to mention names, but I know them. Taha, for instance, the guy can roll on the bed like he's doing a rollings. So that's what happens. Why? Naturally, you don't want to put pressure on one part of your body. Otherwise, you would develop what we call the bed sores. Okay, that place will undergo necrosis because of too much pressure at that area. It's just like if you are pregnant. Okay, none of you is pregnant yet. But then ask your mothers when they were having you. They can't lie on their on their back. Why? Because little Faustina will be putting pressure on the lumbar area, and the woman will have pains. So mother has to lie either on the left side or on the right side. Good. So all of these things, in the way they put too much pressure, and you don't take care, the vena cavas or will be compressed. Then mother will not have enough blood flow to the brain, and that will mean that you, the baby, will also suffer for it. That is just by the way. But over here, the person has developed a dark brown lesions. Again, it's confirming what we're talking about. A dark brown lesions along the backbone. Soft tissues are swollen in the areas of macerations. There is a foul smelling liquid. Guys, what type of, what type of necrosis is it? And this, we are dealing with what? Bed sores. Bed sores. All right. So the answer is E. Okay. A patient is 20 years old, an athlete. He addressed a doctor with complaints of fatigue, fever of 38 to 40 degrees. The liver and the spleen are enlarged. Lymph nodes on palpation are slightly enlarged, dense, and painless. Blood test, 100 gram per liters. Erythrocyte is that leukocyte, leukogram. Guys, look at leukogram. 68% of blast cells. 68% of blast cells. Again, blast should not be more than 5%. So if you have leukogram with 68% of blast, now don't forget, blast cells are more or less like undifferentiated cells, isn't it? I mean, they've not matured. They are immature cells. That's what blast means. They are immature cells. The question is saying that cytochemical investigation of the blast cells revealed a negative reactions to glycogen, peroxidase, and non-specific esterase, lipids. Name this disease. Name this disease. First of all, having a blast of 68% is a sign of what? Who can tell me?
Leukemia.
Leukemia. Thank you. Leukemia. And we have already established over here that when you have leukemia, you now have to go to the next step to ask yourself, what kind of leukemia am I looking at? Could it be that's lymphocyte origin, or myeloid origins? Isn't it? You have to be checking out of what? I mean, checking these things. But then again, for us to have a lot of blast like this, it means that these cells have not even what? Undergone differentiation. They've not yet undergone differentiation. If they had undergone differentiation, the blast wouldn't be more like this. So over here, without wasting a lot of your time in analyzing this question, simply we are looking at what? At an acute undifferentiated because of the too much blast cells, guys. Too much blast cells. Take note of that. So please take note. So your answer here is what? Is A. We have seen questions that deals with the lympho origin and then the other origin. Now again, over here, we cannot also tell whether it is of a lymphoid origin or it's of a myeloid origin. Why? Because leukogram didn't tell us more information. Leukogram is not telling us more information. Leukogram is not giving us more information. So we cannot be specific on the type of leukemia that we are talking about. But of course, we can look at this as an undifferentiated leukemia and even look at the leukocyte. It's even just 4.4. It looks normal, but if you go to the blast, Charlie, there's a problem. So please, let us take note of some of these things. Impression smear of a mucosal biopsy material has been obtained from a patient with a peptic ulcer disease of the stomach. Peptic ulcer disease of the stomach. Guys, do you remember we talk about, first of all, who can tell me the types of gastritis?
Atrophic.
We have type A, type B, type C. Guys, don't forget these things. We talked about these things. And of course, you are representing what? The atrophic. Very, very, very correct. All right. However, look at the question over here. Talking about the peptic ulcer disease. First of all, if it is not an atrophic or a mucosa line that has been stripped off, what else can cause ulcer disease? What bacteria can cause ulcer? For which we always do tests for. Who can tell me? Helicobacter. And that is why anytime you are giving that triple therapy, you know, if you treat ulcer, you have to give a triple therapy, isn't it? Triple therapy. Protein pump, because it could be from the from the gastrin that have been produced, we contain a lot of what? HCl. Okay, so that one is destroying the mucosal lining. So you can give a proton pump inhibitor, then you have to give what? An antibiotic, then you have to give even a protozoa, like metronidazole. So you can give omeprazole, which is a proton pump inhibitor. You can give amozoclav, which is, or ambrosol, which is an antibiotic, a broad spectrum antibiotic. And you can also give what? Metronidazole. All of these things come together to help us fight against anything sort of these things like Helicobacter bacteria. So over here, you are looking at what? C as your answer. A patient after disrupted cerebral circulation has developed paralysis. Choose the anticholinesterase drug, guys. Anticholinesterase. This question, I think Mirabel has answered a question like this before. I mean, has asked a question like this before. If I'm correct, I've forgotten. But who can tell me? Anticholinesterase drug. Proserine. Thank you. Proserine. As simple as that. So please, over here, this inhibits cholinesterase activities. But that's what the question is asking us. Question is not asking you about any paralysis, or it's not asking you about any blood circulation, or no. It's just asking you what anti-cholinesterase drug should prescribe. Just guys, gingerly go and give your drug and go. Don't go and do yourself. Don't go and complicate your things. But if it's suffering from cerebral circulation, so why can't? Please don't stress yourself. All right. So this is what proserine. All right. And by now, you should know how to treat it when there is intoxication. You should know. 30 minutes after drinking mango juice, my favorite juice. I like mango a lot. A child suddenly developed a local swelling in the area of the soft palate. 30 minutes after drinking this, there is swelling which impeded swallowing. That is serious. Eventually, respiration, that is even more serious. Mucosa of the swollen areas was hyperemic and painless. Blood revealed eosinophilia. Guys, what are you thinking about?
Allergy.
Guys, allergy. And look at it. Temperature was normal. Analysis of there's a history of even bronchial asthma in the house. History of bronchial asthma. What kind of edema? Guys, don't waste your time. This is simply what? An allergic reaction. Allergic to what? To the mango juice. It's not inflammatory. In inflammatory, you will see temperature. And that's why even Krok has even helped you by telling you that temperature is normal, so that you don't get this question wrong. If you get it wrong, they should give you -20. They should give you -20 because they've already told you temperature is normal. So why are you going to say this is an inflammatory problem? Don't. All right. So over here, we are looking at what? At an allergic reaction. Of course, in allergic reaction, what is released? Histamine, isn't it? Then histamine will cause the mast cells to cause, histamine from the mast cell to now cause cell to undergo vasodilatations and things like that. And that's where the eosinophils also migrate from the blood and then to the tissues. And don't forget IgE, hemoglobin E is also activated. So please don't always forget. All right. So over here, you're looking at what? At A as your answer. Now, during examination of a patient, a doctor during examination of a patient, a doctor should use anatomical definitions of anterior abdominal wall. Guys, anterior abdominal wall. How many do we have, guys?
9 squares.
9. Thank you. 9. 1, 2, 3, 6, 9. Very good. You know this already, so I'll not even waste my time. So this is what? C. Please, if you are lost, we've done these things. In fact, we've done almost everything over here. We've done everything. So please, if you are lost, I beg you, visit the videos. A child has a wound located posterior to the mastoid process. If I were you, I'll put my hand on the mastoid process so that I can picture what they are talking about. So, bright red blood flows from the wound. That means an artery has been damaged. Those of you who follow me on who follow us on the Instagram, you know, one time I posted a picture on blood coming from an artery and blood coming from a vein. Who here is following me and has seen that video? I mean, has seen that picture? Okay, nobody. Well done. Clap for yourselves that you're not following me. I'll mafia all of you one by one. But technically, blood that is coming from arterial side, they are always bright red. And the ones that come from the venous side, they are a little bit what? Dark. So please, if you're not following me, do well to follow us on Instagram because we post some of these images we're talking about over there for you. And sometimes we ask you some questions to answer for us. It's medent_edu. Go there and follow us. All right. Now, damages are the branches of the following artery. Now, sorry. So now we are going to be talking about the blood vessel that is supplying the posterior area of the mastoid process. The posterior area of the mastoid process. That's why if I were you, I'll just put my hand on the mastoid process. That is behind your ear. Behind your ear. Behind your ear. That is where the mastoid process is. So the artery that's located posterior to it. So first of all, what could you be thinking about? Now, don't forget over here, they're even saying, maybe you might think about the tempora because the tempora is around that area, isn't it? Which, of course, you are not far from right. But over here, they're saying what? Superior temporal artery. It can't be the superior temporal artery. No. So, our next thing that makes sense to us will be what? The occipital artery. The artery around your tikopo, the back of, your occiput, around your occiput, that area. In Ghana, we call it, I've forgotten. Tikopo. So please, that artery around that area supplies the posterior area of the mastoid process. Actually, we call it the ocular branch. Ocular means ear, isn't it? The ocular branch of the occipital artery. The ocular branch of the occipital artery. This artery is what supplies those areas. But the exact one is what? The ocular branch. Ocular, or ocular. Auricular. That is ear or around the ear. Auricular. Please get the pronunciation right. Auricular. AURICULAR. Auricular branch of the occipital artery. That is what we are looking at. When investigating human saliva, it is necessary to assess its hydrolytic properties. Hydrolytic properties. What substance should be used as a substrate in the process? What should be used as a substrate in the process? So first of all, you must understand that the salivary glands in mammals, they are what? Exocrine glands. They are exocrine. And that means that they produce saliva through ducts. They produce saliva through duct. Now, they can be classified as serous, mucous, or mixed. That is seromucous. I repeat, they can be classified as serous, mucous, or mixed. Now, in serous secretion, the main type of protein secreted is the alpha amylase. Now somebody is nodding the head. If you understand these things, you won't suffer in so many things. Believe me. Again, in the serous secretions, the main type of protein that is secreted is the alpha amylase. So who can tell me the function of the alpha amylase or the function of amylase? It is used in digestion of what?
Carbohydrates.
Carbohydrate. That's what we said. Now, Sambus will tell you that digestion of carbohydrate starts in the mouth. True or false? Digestion of carbohydrate starts right in the mouth. That's because the saliva produces serous secretions which contains this enzyme or protein called what? The amylase. So please, and this helps to break down what? Starch or carbohydrate. So if I don't say carbohydrate, so carbohydrate means what? Starch. Or starch means carbohydrate. They are all what? The same thing. Whilst, of course, the mucous secretions will produce what? Who can tell me? Mucous will produce what? Mucin. These act as a lubricant. They act as a lubricant. Now ask yourself, why is it that before you swallow food, when you are eating your manka, you aware that something will come and then, make the food, some soften the food for you and stuff like that before you do. True of us. True of us.
True, Dr. BAHA.
Exactly. Because you have been eating a lot of manka, isn't it? I know they will say they don't eat manka. They'll think they eat fufu.
No, I don't eat manka.
Don't eat manka. No problem. Me, manka was my favorite. So
I eat banku.
you eat banku. No problem. By the time you finish, all your money is finished because you are eating banku. Because I know we don't have banku in Ukraine. We don't have those of you eating fufu and banku even in Ukraine. Ha! Give me money, before your money get finished. All right. So over here, we are definitely dealing with what? With starch as our answer. So your answer here should be what? Should be D. Starch. All right.